Good day, everybody. This is Dr. Sanjoy Sanyal, Professor, Department Chair. So this is going to be a demonstration of the temporal region. This is a supine cadaver. We are standing on the right side. Before I go to the temporal region itself, first let me give you an overview of the complete dissected area that we have exposed here. So this is the GALEA APONEUROTICA, which we are reflecting. That is the aponeurosis of the epicranial or the occipitofrontalis muscle that we have reflected. The next structure that we see here, this is the lateral extension of the GALEA APONEUROTICA. This is the superficial temporal fascia. So we have reflected that also. Okay. Under that is the temporal region that we are going to describe shortly. But before I go to the temporal region, let me give you a quick overview of the other areas so that we get the orientation. This is the zygomatic arch where my hand is moving right now. And under that we can see the structure here. This is the parotid gland. This is the superficial part of the parotid gland, and this is the parotid duct, which we have cut here just to show the muscle which is right underneath. This is the masseter muscle. On lifting up the parotid gland, we can see the various neurovascular structures here. And finally, this is the sternocleidomastoid muscle. And we can see this nerve crossing in front of it. This is the great auricular nerve, which was heading towards the parotid gland. Having mentioned these structures, now let's come back again to the temporal region, because that is the main focus of the present dissection. So this is the superficial temporal fascia, as I mentioned earlier. It's the lateral extension of the GALEA APONEUROTICA. And if you look carefully, we can see running on the superficial temporal fascia is this blood vessel here. This is a branch of the superficial temporal artery. And we can see these venous channels. These are the tributaries of the superficial temporal vein. And also running will be the auriculotemporal nerve. These all come through the parotid gland here. So this is the superficial temporal fascia. In surgical parlance, we also call it the temporoparietal fascia. We are going to now reflect this. This temporoparietal fascia or the superficial temporal fascia was attached to the zygomatic arch, and we have cut it out from there. Now, having reflected this, now let's come to the temporal region proper. First, let's start with the clinical correlation. A person comes to you with a blunt injury to the temporal region. He becomes unconscious, he recovers, and after some time, again he becomes unconscious and he doesn't recover. That is what is known as the lucid interval. When you take an emergency CT scan, you find a football-shaped opacity on the right temporal region. What exactly is the problem? The problem is he has got a rupture of the middle meningeal artery from a fracture of the Pterion, and that has produced what is known as an extradural hematoma. So let's take a look at the temporal region and understand exactly what has happened and how we should deal with it. This structure which we have cut open, this is the deep temporal fascia or the temporal fascia proper. This is attached to the superior temporal line all the way around like this. It is located under the temporoparietal fascia or the superficial temporal fascia. This is the true temporal fascia, and we can see it is tough structure and it is leathery membranous. If you were to take a look at this deep temporal fascia or the temporal fascia proper, we see that on the top it is quite thin, though it is tough, but lower down at its attachment to the zygomatic arch, it becomes very thick. Why does it become thick? That's because it splits into two layers, an outer layer and an inner layer. The outer layer gets attached to the outer margin of the zygomatic arch, and the inner layer gets attached to the inner surface of the zygomatic arch. There's another important function of this deep temporal fascia. If you take a look downstairs, you'll find that there is this tough muscle here. This is the masseter muscle, which takes origin from the zygomatic arch, and the fibers, they go down and they get inserted onto the masseter tuberosity on the lateral aspect of the angle of the mandible. This is a very strong muscle of mastication. When this masseter muscle contracts forcefully, it exerts a very powerful pull, downward pull on the zygomatic arch. And rarely, it can even lead to fracture of the zygomatic arch. So therefore, the function of this deep temporal fascia is to give a counter traction to the downward pull of the masseter muscle on the zygomatic arch. So this is an important clinical functional aspect about this deep temporal fascia. Taking partial origin from the undersurface of this temporal fascia was this muscle here. What is this muscle? This is the temporalis muscle. The temporalis muscle takes origin from the inferior temporal line, and the fibers, they converge inframedially like this, and my finger is going down inside. And the fibers, they go under the zygomatic arch. My finger has gone under the zygomatic arch. And they get inserted onto a narrow insertion at the coronoid process of the mandible, which you cannot see here, and to the temporal crest of the mandible. So that is the full temporalis muscle. This is a muscle of mastication, and it's a very powerful muscle of mastication. When we clench our jaw, we can feel the temporalis muscle contracting. Now, if you take a look at the fibers, we can see that there are two sets of fibers. The posterior set of fibers are almost horizontal, and the anterior set of fibers are almost vertical. And of course, the fibers in between are in between the two. The anterior set of fibers, the vertical set of fibers, are responsible for closing the jaw powerfully, that is elevation of the mandible. While the posterior set of fibers, which are almost horizontal, they are responsible for retrusion of the mandible, which is one of the steps which happens when we do side-to-side chewing movements or open the jaw and close the jaw. This is for retrusion of the mandible. I will draw your attention to this blood vessel here. This is a temporal vessel, which is a branch of the maxillary artery second part. In most dissections, we have seen that deep temporal arteries and the deep temporal nerves, they all run deep to the temporalis major muscle. Sometimes they can run superficial also. And in this case, it is running superficially. Now we have lifted up temporalis muscle, and we can see this depression here. This is the temporal fossa that I was alluding to earlier. What are the boundaries of this temporal fossa? The temporal fossa is, the floor of the temporal fossa is formed by 4 bones. The frontal bone here, the parietal bone, the squamous part of temporal bone, and a little bit here, which is the greater ring of sphenoid. And at the meeting point of these 4 bones, there's an H-shaped suture here, approximately here, which is referred to as the pterion. And running right under the pterion is located the anterior division of the middle meningeal artery, which is a branch from the first part of the maxillary artery. It enters through the foramen spinosum and it runs under the pterion. So if there's a fracture of this pterion here, it can rupture the middle meningeal artery anterior division, and that's what produces extradural hematoma, which compresses on the motor cortex of the brain and can lead to even death of the person. So therefore, when we are faced with a person who has got a suspected extradural hematoma, which is obvious from a CT scan, what are we supposed to do? What we do is we make what is known as a Burr Hole, a temporal Burr Hole. We slit open temporalis muscle, we split the fibers in the direction of the fibers, and we reach the pterion. How do we locate the pterion in a living person? There are several ways of doing it. One is to feel the zygomatic arch and go from the midpoint of the zygomatic arch, go 1.5 inches above that. That is the easiest method. The second method is 1 thumb width behind this ridge of bone here, this is the frontal bone, and 2 finger width above the zygomatic arch. Where the 2 meet, this is the location of the pterion. That's the second method of locating it. And there's a third method of locating it using the tragus of the ear as the landmark. By any one of these methods, once we have located the approximate location of the pterion, we're supposed to cut this open, and once we reach inside, we are supposed to make an opening in the floor of the temporal region. And we have to evacuate the extradural hematoma and ligate the bleeding middle meningeal artery. And that is a life-saving procedure. So that is exactly the procedure that is done here. Having mentioned that, there are other procedures also which are possibly done in the temporal region. Like for example, if you want to remove an astrocytoma or a tumor from the temporal lobe of the brain, what we do is called an osteoplastic craniotomy, where we make an incision like this based on the superficial temporal artery. This was the superficial temporal artery which I had mentioned earlier. And lift up the whole thing, the superficial fascia, deep fascia, the temporalis muscle, and we cut open a slab of bone here and lift up the whole thing. That is known as osteoplastic craniotomy. And after we have removed the tumor or whatever, we can put the bone flap back. The bone regenerates by means of the vascularity provided by the superficial temporal artery and the muscles. So that is osteoplastic craniotomy. So these are some procedures which are performed in the temporal region and some clinical correlations pertaining to the temporal region. Thank you very much for watching. This is Dr. Sanjoy Sanyal signing out. Sep is the camera person. If you have any questions or comments, please put them in the comment section below. Have a nice day. Please like and subscribe.